Hi, everybody. So we've just let everyone in, and I can hear that there are lots of people joining the Zoom. So this is very exciting. Welcome, everyone. Uh, while we're just going to give, before we start, we're going to give everyone just a couple of minutes to join us. So while we're waiting, if anyone wants to pop in the chat where they are and what they do, where they're located, where they're joining the Zoom from. I can see a few EPC people there actually. Join the chat. The best thing, one of the best things that we can do to make these webinars interesting is to be part of a conversation. So pop in the chat, click on your chat function and tell us where you're joining us from today. Who's going to be first? From EPC. Hi, Simone. Danielle Chu is from PCSE, from the Philippines. Wow. Thank you, Lariosa. Wow, from Cebu. Wow. From PCAS. Hi, Emily. Thank you very much for joining. From Bethlehem. From Nepal. How amazing is that? Wow. From the Loddon Valley. Hi, Kai. Thank you for coming. Gabe. Hi, Gabe. From Adelaide. Gee, we're from everywhere. From Patricia from RMH. This is my favourite thing about these webinars is that it just brings together palliative care nurses from everywhere. We'll just give us a few more minutes while everyone is joining. So we've got Sabrina from Wangaratta, Kylie. Hi, Kylie. We know Kylie. Hi, Kylie. So we'll just have a few more minutes from the Sunshine Coast. We're all from all around Australia. It's very exciting. Palliative Care Southeast. Hi, Danielle. Thank you for joining. Xuan, we know Xuan. Xuan from Beijing. Hi, Xuan. If that's a Xuan that we know from our work. So just for those that have just joined, we're just going to give everyone a few more minutes and then we'll get Kathryn to start. 34 now. That's amazing. This is the best bit of Palliative Care Nurses Australia is that there are palliative care nurses across Australia, but around the world too. So it's great. All right. So I think let's get going. Thank you, all of us. Thank you, everyone, for joining us today. And as I said, this is the best bit, I think, of Palliative Care Nurses Australia is that we get to choose topics that are relevant and very interesting to community palliative care nurses and put on a forum for us to learn together. And it doesn't matter where you are, even around the world, we can bring people together, which is wonderful. So thank you for joining us. So I'm just, before I start and introduce our guest speaker, I'm going to just do an acknowledgement of country. So Palliative Care Nurses Australia acknowledge the Aboriginal and Torres Strait Islander people are the traditional custodians of the lands and waters that we live on and we work on. And we respect their historical and continuing spiritual connections to the country and to the community. And we pay our respects to their elders, past and present. And we'll all be speaking or all be joining this webinar from different lands, but I'm on the Wurundjeri land. So now that brings me to introduce our guest speaker, Kathryn Bennett. And I feel sorry for anyone I work with because often what happens is I make eye contact with someone and you work with me for long enough and they end up doing a webinar like this. So Kathryn often sits near me and that's how she got roped into this talk. She is a nurse practitioner at Eastern Palliative Care in Melbourne. And she's been a nurse practitioner for 10 years and a nurse for 18, which is pretty amazing. So Kathryn is she actually came in, the idea for this talk came out of her coming and talking to our new nurses about the PBS and the TGA, which really are things that people don't necessarily know much about. So thank you, Kathryn, for joining us. And without further ado, we might get going.
Thank you, Sarah, and thanks everyone for coming this afternoon out of your busy schedules. So thanks, Sarah, for doing that acknowledgement of country as well. I've actually been nursing for over 24 years, but 18 years in palliative care, and it's been 10 years now since I was endorsed, which Sometimes feels like 20 and sometimes feels like 2. So, but thank you very much. So today, really, I just wanted to talk a little bit about you know, the TGA and the PBS and how some of that relates to our community palliative care medicines. And really, sorry, my view's not great here. Now I can't see anyone, but that's okay. So really it's sort of the National Medicines Policy is a high-level document and framework which outlines how the Commonwealth Government work with state and territory governments, healthcare services, medicine industry, the consumers and the media, really to ensure that Australians have fair and affordable access to the medicines that they need when they need them. It focuses on the availability of medicines and how they are used. It also focuses on medicine services, and these services help make sure medicines are used correctly and safely. The policy covers the research and development of medicines, and it looks at how medicines are manufactured, regulated and controlled, evaluated or assessed, supplied and dispensed, and how they're stored and accessed. So the quality use of medicines is one of the real central objectives to the National Medicines Policy, and it is essentially about ensuring that medicines are only used when they are needed by selecting management options wisely. Which includes considering the place of medicines in treating illness and maintaining health, and recognising that there may be better ways than medicine to manage some disorders. For instance, you know, lots of people have got colds and flus at the moment, but probably don't need antibiotics. So it's about making decisions about whether or not someone needs the medicines at the time. It's also about choosing suitable medicines if a medicine is considered necessary, so that the best and available option is selected, taking into consideration, you know, the individual, the client, the clinical conditions, the risks and benefits, the dosage and how long we expect to treat people for, any coexisting conditions, other therapies, monitoring considerations like regular blood tests for people that might be on warfarin, and the cost for the individual, and not only the cost for the individual, but the community and the health system as a whole. And I'll show you some of those costs further down. We're also using medicines safely and effectively to get the best possible results by monitoring outcomes, minimising misuse, overuse or underuse, and improving people's ability to solve problems related to their medicines, such as being aware of the adverse events that could happen, what are normal side effects, what are abnormal side effects, and also helping them manage multiple medications. And we know in our cohort of people, there's certainly a lot of polypharma. So the Therapeutic Goods Association, or the TGA, is responsible for ensuring that therapeutic goods are available for supply in Australia and that they're safe and fit for the intended purpose. Therapeutic goods include medicines, but they also include medical devices, blood and blood products. And the medicines can be either medicines that are prescribed by a doctor or dentist, medicines that are behind the counter at the pharmacy, in the pharmacy in general, and also medicines that we find in supermarkets. Complementary medicines include vitamins, herbal and traditional medicines, and these are all regulated by the TGA as well. Medical devices and products used to test for various diseases. So for instance, in vitro diagnostic devices, and we've probably all used them on a regular basis because they include rat testing and things like that. And also blood tests, vaccines, blood products and other biologics. And the TGA is also oversees and regulates the manufacturing and advertising of all of these products as well. So for the purpose of today, I'm really only going to focus on medicines through the TGA, not all of the other devices. But a medicine needs to be either listed or registered with the Australian Register of Therapeutic Goods, or the ARTG, to be lawfully supplied in Australia. And the regulation of medicines includes sort of the following, really, which is the classification of medicines based on the different levels of risk. to the person taking them, implementing appropriate regulatory controls for the manufacturing process of medicines, complying with process standards and labelling batches so that we can track them if there's any issues. Medicines assessed as having higher level of risk, which generally your prescription medications and some non-prescription painkillers and things are evaluated for quality, safety and efficacy. But medicines that have ingredients with a lower risk tend to only be, and they're generally the medicines that we buy over the counter and a lot of our complementary medicines, they're only really evaluated for quality and safety. The way that you tell this when you're in a pharmacy is looking at the labels that are on the medicine. So the AUSTL that means that medication is a listed medication. The listed assessed means that it's listed, but it's also been assessed for efficacy. And the registered medications are generally the medications that require, so they're registered and they're tested and regulated for quality, safety and also efficacy. So it's important that, you know, we sort of know what they are. There are some medications or products like saline solutions and different things that don't have those on them. And once available for supply, medicines are subject to monitoring by the TGA. And this monitoring includes comprehensive adverse event reporting program. So that's essentially what the TGA does as the overarching regulatory body of medicines in Australia. So medicines that are not registered or listed on the ARTG can be brought into Australia when there's shortages. And I'll talk a bit about some of the shortages that I'm sure you're well aware of, but they can come in via their special access scheme and also Section 19A permits. There's also unapproved medications can also be provided under the SAS scheme for medications such as levomethazine and some of the medicinal cannabis products also coming under SAS at the moment from overseas. So the Pharmaceutical Benefits Scheme started in 1948, and it was really to balance good health results with the cost of medicines. Before, and it's really a key component of the National Medicines Policy and access to affordable medications for people who need it. So before a medicine can be listed on the PBS, it first must be approved for use in Australia by the TGA. And the sponsor of the medicine, who's usually the pharmaceutical company, applies to the TGA to have the medicine included on the Australian Registry of Therapeutic Goods so that it can be actually sold in Australia. The sponsor must provide evidence at that time, such as clinical trials, that the medicine meets the required standards of quality, safety and effectiveness for the intended use, noting that some of these medicines are actually used for multiple conditions. However, the medicine will not attract the Australian government subsidy unless the sponsor applies and is successful in having their medicine listed on the PBS. So applications for the PBS are considered by the Pharmaceutical Benefits Advisory Committee, or PBAC, which is an independent expert body appointed by the Australian government. A new medicine cannot be listed on the PBS unless the PBAC makes a positive recommendation for the listing. And the PBAC must take into account both the cost, clinical effectiveness of the medicine when compared to other treatments that might be available already for the same condition. Most PBS medicines are dispensed by community pharmacies and are used by patients at home. And these are called general schedule or Section 85 medicines. There's also some PBS medicines that are supplied through the special arrangements where normal supply through community pharmacies is not suitable. And that's called Section 100. And these are the medications that are often given in hospitals because they can't be given in community or in the community, such as chemotherapies, immunotherapies, IVF medicines, and some actually can be provided through a community pharmacy, and they're normally things like the opioid replacement therapies that are available. I should have got myself a water. Anyway, so the PBS. So the PBS really is available to anyone who has a Medicare card. And if you're an overseas visitor from countries that have reciprocal healthcare arrangement with us, you can also access the PBS. So there are countries like Belgium, Finland, Ireland, Italy, Malta, the Netherlands, New Zealand, Norway, Slovenia, Sweden, and the UK. So the cost of the medicines definitely need to be registered on the ARTG to be eligible for the PBS, like I've mentioned. And most of the cost of medicines is covered by the PBS, along with co-payments. Oh, sorry. The co-payment amount depends on whether the person qualifies for a concession card. The co-payment is reviewed pretty much on January 1st every year, and there's also a safety net threshold that people can reach. So the cost of scripts at the moment in Australia are $7.70 for concession card holders, $31.60 for general patients. The safety net's up to just over $270 for concession card holders and over $1,600 for general patients. One of the things that we do try and recommend to people is to try and get their medicines from the same pharmacy, because often the pharmacies can keep track of it. Unfortunately, pharmacies don't talk to each other about, dispensing, apart from maybe opioid or S11 drugs like the benzos, which go on safe script. So it's really important to try and keep the same pharmacy if we can. And if you do reach that threshold, or our patients reach that threshold, they can actually apply for a safety net card, which gets their medicines considerably cheaper, which is free for concession card holders, and it's also $7.70 for the general patients. One of the things that is a bit of a new initiative at the moment, and this might be just handy to know, especially we know that a lot of our patient population have a lot of medications, and the cost of these medications can be quite excessive at times, but they now have 60-day prescriptions. So medications that are used mainly for chronic diseases. So there's currently 200 medicines available in this program. Often, unfortunately, there's not many palliative care medications in that list, but there are lots of chronic disease management medications such as antihypertensives, diabetes medication, lots of the anticoagulants and different things like that, but they are hoping to have 300 medicines available on that program by September this year. So that's good. And essentially what that means is that a month's supply of a medication, so generally medications are given out at a month at a time for those kind of medications, they can actually get 2 months supply for the same cost as 1 month's supply. So it's considerably cheaper over the year. So in terms of our expenditure, it may surprise some people to know that we spend about $17 billion a year in that last financial year on PBS. So this is the amount of money that the government subsidises medications for all Australians. And there's quite a considerable increase over the last 12 months from the previous year, which is up by about 15%. So there's about 928 different medicines, and they have about over 5,000 brands, and that's how many have been that are currently on there as of June last year. And the prescription volume is certainly increasing by almost 4% a year. So I'm not sure, and Sarah, you might be able to keep track of the chat here, but I'm just wondering if anyone might hazard a guess at which drug was the number one drug expenditure wise for that financial year. All so right. You can fire away and put some answers in the
Who wants to have a guess? Oh, well, hold on, mine's going down. Here you go. Someone said a statin.
Close.
Antidepressants. Is anyone correct yet?
No.
No? All right, keep guessing.
Think about what's happened in the health sector over the last 4 years.
Yeah, COVID related.
So, yeah,
Yeah.
molnupiravir is only 500, well, I shouldn't say only, but over 500,000 prescriptions at a cost of 640 million.
Wow.
To the PBS, which is quite, and really the government is subsidising on each prescription about $1,100 for one of those prescriptions. So we should have probably all bought into that, I would have said, if we knew that that was. But so some of the people were right though, in terms of the higher subsidised prescriptions. So the number ones are the statins, as most of us know. Tajan used to make it into the top 10 when I did this talk, probably 5 or 6 years ago. It's dropped out of the top 30, but oxycodone is in there, and even Panadol has made an appearance down there. I can't see the bottom of my thing because I've got the Zoom toolbar there, but I think that came in at number 30, and so that's PBS. People can access paracetamol and Panadol Osteo in those larger quantities via the PBS. So I guess the question is why is this so important, and why am I telling you or giving you a better understanding of all this? And that's because we all play a role in the management of medicines in the community. We should all be thinking about the quality use of medicines, and perhaps when I first started in my nursing career, it was in the hospital environment where you don't even think about the costs of medications. And then I moved into community palliative care, and I still didn't really think about the cost of medications much, and I would ring the doctor and say, I want this, 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 and this, and got upset when they didn't always do what I asked them to do. But when I became a nurse practitioner and I was training to become a nurse practitioner, I learned a little bit about all of what I've just told you, and especially the quality use of medicines. And when you see how large our expenditure is in the PBS, we all play a role in trying to keep that PBS viable. So I have certainly changed my views on medication and medicine prescribing and different things as I became a prescriber. But I think it's really, and it might be why sometimes when we're pushing for a doctor to write a script for something that, they may be a bit reluctant to prescribe if they don't feel it's necessary. And it's really important that we're aware of all of this because it keeps medicines affordable and accessible to our most vulnerable. And this also, what I've sort of told you about, also leads into understanding the processes when we aren't able to access medicines or there's medicines shortages, and we're all very aware of those over recent times. So the PBS, and I've done some little cut and paste here of the different pictures. I'm not sure how I get to see. Oh dear.
On top of your screen, Kathryn, there should be a little bar that says view, and you can
anyway, I look, I'm a better nurse practitioner than I am an IT person, so I won't worry about it. I can see it on my notes, but essentially the PBS is broken up into a few things, and I don't know if anyone really gets onto the PBS, but I do recommend it because it's really good for us to know what's available to clients and patients under the PBS. And if I'm ever sort of looking for, I probably didn't use it as much before I was a prescriber, but I do recommend any sort of nurses really, or anybody that has got an interest that isn't a prescriber, to have a look at it. But generally things sit under the general schedule, and they can be prescribed to anybody without sort of restriction. There's medications or medicines that can be prescribed under the repatriation pharmaceutical benefits. So some medicines like Caloxyl and Senna, for instance, are available to people that have got a DVA card at a subsidized price. So it's really sort of important to just have a look and see if that's the case, because it can certainly reduce the cost of medicines. Hopefully pharmacists are also sharing this information with our patients, but we can't always assume that other people are doing that. There's medicines in the prescriber bag, and I remember what's down there. I can't see the bottom, but it's midazolam. Now, we all know midazolam's not on the PBS, but it is on the PBS for the prescriber bag. And just so that you get a bit of an understanding of what this is looking like. So on one side, the MP and the NP means that a medical practitioner or a nurse practitioner can prescribe it. It tells you the strength that the medication comes into. And then the DPMQ is really the dispensed price for the maximum quantity, okay? And this is the base price. So this isn't necessarily the price that the patient will pay, but it's because there's sometimes agreed additional fees that go on top of that. The maximum safety net figure there is that's the maximum amount that can be put towards someone's safety net. So some of these medications might actually cost more than what is written there. So let's say, so the next column is the general patient charge, and that's the maximum amount that the patient will be charged. But you can see someone might get charged $21, but only $17.86 will be put towards their safety net. So that just sort of gives you a bit of an idea of the cost of these. So restricted benefits. So restricted benefits are when a medicine is only listed on the PBS for a particular condition, or it's restricted. So for instance, morphine is on the PBS for pain only, severe pain that hasn't responded to non-opioid analgesics. So interestingly enough, lots of people don't, even though we use morphine and oral morphine, if we can get our hands on it, although we use it for shortness of breath, it's technically not on the PBS for shortness of breath. So fortunately in palliative care, we can always, not that I'm suggesting that we do anything dodgy, but we can always suggest that it's for pain and for shortness of breath. The only thing that is on the PBS for shortness of breath is actually Kapanol, but our oral liquid opioids are certainly not on the PBS for shortness of breath, but you can get away with that by saying that it's for pain as well. So authority required and streamlined. Now, this is where I think it's really helpful, because sometimes when we're looking or requesting medications from GPs, they only give a certain amount. This is an area, and I'm going to go into the PBS in a minute and I'll just show you what that looks like. But authority required, but they're streamlined, means instead of the person needing, or the GP or the prescriber needing to ring the PBS to actually get a authority code, the code, a streamlined code is given. So as long as they put it on an authority script with that code, then you can certainly increase volume. And so one of the things that's come about in the last, I want to say 12 months, but time flies these days, it could be perhaps in the last 2 years, is that morphine ampules for palliative care patients has got a streamlined authority now, which means that you can get 10 ampules at a time with one repeat. And we know how helpful that can be if someone is requiring regular sort of injections, or they've got a syringe driver, because previously, without an authority that we used to ring Canberra for, essentially, to get, you would only get one box at a time. Obviously, if you do need more supply than this, so let's say you've got a syringe driver and you're using 5 amps a day of a particular medication or something like that, and you want to get a week's supply, then you do have to either ring. The quickest way is to ring the PBS and get an authority, and you just need to explain the condition that you're treating and why you need as many as you do. And it's fairly easy. You just ring and say, I've got a syringe driver going and I've got this much. So it is more time consuming for the prescriber, but it's still very possible. And then authorities like this are also used for people that might have cancer pain, non-cancer pain, and on stable pain medications. And instead of going back and forth to the doctors, every week or two to get their scripts, they can get a month's supply. Generally, those sort of authorities are done in advance with the GP, and they actually send off a request, and then the scripts are sent to the person themselves. So just to give you a bit of an idea of the costs, I guess, associated with different choices. Now, hydromorph, I know in liquid we tend to use because people either have swallowing issues or we're trying to get a lower dose. But these are currently the options for hydromorph that are available on the PBS, and the Hikma brand and the PMS brand. You can see that the cost essentially to the government for those are $350 per bottle and $434. So obviously the safety net or the general patient charge kicks in, so they're not paying that, but they are certainly, the government is paying the rest of that. Whereas if we sort of thought, well, actually, you know what, I think that they could get away with tablets, then the cost really to the government is $24. So it's certainly decisions like this, and I really struggle and have always struggled prescribing hydromorphone liquid, because I find that the 470 ml bottle or 73 ml bottle and now the 500 ml bottle seems like an excessive amount of opioid to put in homes when we may not use much, and it's quite a strong analgesic. So sometimes I do consider whether I need to do that option, and sometimes I go an option like oxycodone if because that is certainly much cheaper. So palliative care medicines that aren't on the PBS, as we all probably know, midazolam is one of them, cyclizine. Now, it's really important to remember. So I think sometimes, palliative care nurses, we love to prepare for everything. And so when people are at home because we don't have that drug cupboard there, we like to get midazolam in, maybe Rivotril drops, Maxilon, an opioid, and maybe some Buscopan or something like that. But if we're not expecting that we're going to use all of them, I try and get maybe 3 of them instead of all 5, and then perhaps wait and see if we need the other ones. So sometimes people are either not planning on being at home for end of life. So sometimes I, don't always put them in if the plan is not to be there when they need injections. But, a box of midazolam in different pharmacies around the country can certainly be up to, $50 a box. Same with cyclizine. Sometimes it's a bit frustrating, as we know, in community palliative care, when people are discharged on cyclizine in a driver, let's say, and they might be using 200 or 300 milligrams, they're 50 milligram ampules. That's sometimes 4 to 6 ampules a day, and they're not told about the cost of that before they go home. And I've had, calls from especially rural areas where that's been the case, and it may be the only drug that's available to them, but I think it's really important that when we're recommending medicines that are not on the PBS, that we're really open with our patients and families about the cost of those. Lorazepam's not on the PBS. We use that a fair bit for shortness of breath. Glycopyrrolate was the new kid on the block in terms of secretion management. A lot of the research certainly says that there's not a lot of difference between atropine, buscopan, and glycopyrrolate. There's certainly a big cost difference though. So glycopyrrolate and buscopan don't cross the blood-brain barrier, so they're really good alternatives in people who might have cognitive impairments, dementias, those kind of things, or at risk of cerebral irritation. But my preference would always be for buscopan. You can certainly, for palliative care patients, you can get increased amounts with a streamlined authority, but a box of glycopyrrolate can cost you anywhere between $30 and $50 as well. So we know that the dose is 0.2 to 0.4. So you can easily go through a box in a day. So that's, often influences which medicines I might prescribe. As I've mentioned, oral morphine liquid is not on the PBS for shortness of breath, and medications like levomethroxamine, we need to get through the SAS, but they can also be very expensive in the community. So I thought I would just, fingers crossed this works well, is just show you, if we're looking, I'll just show you what it looks like when you go. So this is just morphine.
It's not moving from the slide, Kathryn, unfortunately.
Why?
So I presume that in that link though, you're going to the website, right? The PBS
Yes.
website. Yeah. So I guess we might, if it's not showing up, I guess
It did the other day when we were.
If you go out of your PowerPoint, and then you share your screen, I think it would work. Do you feel like you're game enough to risk that?
Oh, look, I can give it a go.
Yeah, good on you. That's it. So go minimize that because we can see what you're doing now.
Oh, goodness. I hope I haven't got anything untoward. I did clear my browser. I thought I did anyway. Can we see that now?
No, I still can't.
I'm not sure why. Anyway, that's why I actually put some of these things in as I'm just not going to worry about that. But what I would recommend is that you have a look. Anybody can go into the PBS. If you put in the search bar at the top, you will see, that you can just put in morphine. And I'm really sorry that didn't work, but that did work in test run. But if you put in morphine and then select maybe the ampules, the 10 milligram per mil ampules, you'll be able to see that there's the schedule for palliative care. And then underneath that, it will say authority required streamlined. And if you click on that, you will see that there's a code. So
can everyone see the screen now, the PBS page? I'm sharing it.
It says that, oh, are you? Because you've paused mine, have you?
Yeah, can you see the PBS page? No, you can't. I've got it up now, Kathryn, but if you can't see it, it's probably not that helpful. But it's
not that helpful, but you could probably, can everyone else see it?
Yeah, they can. I've unshared it now. I'll put it in the chat.
So I don't really know how your screen sharing is paused. This is going well, isn't it?
No, it is. It's going really well. Let's just go back to the slide with the two links, and I'll share them in the chat.
Yeah, but it's telling me that I'm going to stop sharing for a second and then I'm going to try and share again.
Yeah, that's worked. That's good. If it's not broken, don't fix it.
Okay. The other link that I put there is a TGA medicine shortage information. So I think that's really helpful if you're, especially at the moment, and I'm going to talk about some of that in a minute, but that's a really good place to go if you're looking for medicines or you hear there's a shortage. It gives you information about, I'm not going to try and do that.
I've just put the link in the chat.
Thank you. But that also gives you some information about the medicine shortages. So I thought, well, I've got a captive audience, this might be information that you might be helpful, but we all know that there's currently issues with oral morphine liquid supply. At the moment, we have 2 brands that are on the PBS that are overseas formulations, and one's a Hikma brand, one's a Martindale brand, and these are currently on the PBS, but they require, to get them into the country, where they require the S19A permits. And these medications come in, essentially they're 2-in-1 medication formulations. They're 10 milligrams in 5 mils or 2 milligrams per mil, and they come in bottles of 100 300 and 500 ml bottles, depending on the brand. They are not registered with the TGA, but are on the PBS, as there's no other alternative at the moment. The problem that we're having with these products is that they're being bought in on these permits, and these permits have limitations and restrictions on how much can be bought in at the one time. So I think it's what they call 100 units. Now, I'm not sure really what makes up a unit, whether it's one bottle or a box of 5, but it's still not that many, given that that is for distribution to everyone in Australia. And the problem is that when they come in, the supply is exhausted very quickly, often because there's lots of back orders, and then they have to apply for a new permit, and often getting these medicines from overseas at the moment is taking 3 to 6 weeks. So we're constantly on chasing our tails, essentially, which has meant that there is very difficult to get your hands on the liquid gold at the moment. The good news is, though, is that in some of my research and annoying drug companies over the last few weeks, trying to find if there's a solution, is that I was told that there is a new, well, it's not actually a new brand, but it's a New Zealand brand. It's called RA Morph, and that hopefully will be available. There's some 1 milligram per mil formulations that are available at the moment, but you do need to know what you're asking the pharmacist to look for. This medicine is actually made in Perth. I'm not sure why it hasn't been our routine supplier. So it's not restricted by the same limitations of overseas import permits, which is good, but they haven't, they're a bit behind with their supply as well. But what they're saying is that the formulations of 2-in-1, 5-in-1 and 10-in-1 should be available early July. And they also suggested that it will also go on the PBS on the 1st of July. So have a bit of a look for that. And it might be that you need to be calling your local pharmacies if you've got an order for something like that, or you know that the doctor's going to do a script for that, that you know specifically what to ask for. The good news is that hopefully this sort of Ordine crisis will resolve towards the end of the year, because Aratex Pharmaceuticals has taken over the sponsorship of the Ordine products. And so it's the same sort of product. So it's already registered with the TGA. So there won't be the issues around permits and things. They're suggesting that these are going to be available late August, but I'll believe it when I see it. And in terms of Hydromorph liquid, the oral liquid, that has got S19A approval till February, but we've got big issues with that. Not only have we got the problems with the permits and the limitations of how much we can bring in, the actual companies that are trying to import it just can't get their hands on any supply from manufacturers. So unfortunately, the Hydromorph issue is a big issue, and that doesn't look like it's going to resolve as easily, perhaps. Well, I say easily, but perhaps as the oral morphine liquid will. But fingers crossed. I'm positive Patsy, they call me, so I'm an optimist all the way through. In terms of other opioid shortages that you may or may not be aware of, Sevrodol tablets have now been discontinued, and supply of them has essentially been exhausted. From as far as I can tell, that no suppliers have any more stock of those. An alternative is Anamorph, which are morphine tablets, immediate release, and they're 30 milligram tablets. These are scored, so they can be broken. So if somebody is taking doses of 15 milligrams or more, I'm not sure exactly how big they are, whether you could break them into quarters or not, but there's certainly that option available. MS Mono has also been discontinued, but I don't think that was widely used, but Kapanol is still available. The Oxynorm capsules have also discontinued. There may still be a bit of supply around, but they are suggesting that there's going to be a new option for the capsules and in those strengths coming later in the year. Looked like it was going to be around September and I can't remember the name of those ones. I should have written that down. But the oxycodone immediate release, the 5 milligram tablets, and the oral liquid is still available. So at the moment, unless there's a contraindication, we're kind of almost forced to do the oxycodone liquid, which is not ideal in every scenario. But if we're after a liquid, that seems to be the main option that we have at the moment. And I think that that might be it.
Well done, Kathryn. Thank you.
I might stop sharing.
Okay. So while you're doing that, there were some questions that came through, and if you're sitting listening and would like to ask a question, just post it in the chat now and I can ask it because we have a bit of time. One question came from Simone at EPC, and she wanted to know, Kathryn, yeah, hi Simone, we know her. Simone wanted to know, because she commented that it was astounding the price of the medications, and she wanted to know if the GPs, did you think that GPs were aware of the cost of these medications?
Look, the quick answer to that is I don't know what the GPs know, but they would be looking at the PBS, I would imagine. I'm not sure how it looks for them now that there's a lot more of this electronic prescribing. I certainly don't have electronic prescribing. Actually, in my other role, I do some electronic prescribing, and it doesn't necessarily come up with the cost of those. So I guess if they're using the PBS website, they should be aware of the cost because it's right there in front of us. But if they're not using that, I'm really not sure what some of the programs, the prescribing programs, actually tell them when they're doing scripts or not.
I had a question, Kathryn, about the threshold for how do the patients know they all have a certain amount of money, a cap that can spend? Is that right?
So if you're a concession card holder, your threshold kicks in once you've spent 277. So that's multiple numbers of scripts that are worth $7.70. Now, most people that we know, especially older people over 80, let's say, have multiple medications, and each one of those scripts every month would cost $7.70, depending on the medication. So that's why I sort of recommend, so unless you're keeping track of that yourself or you're using the one pharmacy, and that's why I do strongly recommend people that are struggling with the cost of their medicines to keep it with one pharmacy, because most of the pharmacists will alert you to the fact that you've reached that threshold and can actually help you apply for that threshold card. Once you've got that threshold card, and this is only for a calendar year, from the 1st of January to the end of December. If you hit your threshold in June or July, that card will then entitle that person to any PBS, only medicines on the PBS. So anything that's not PBS will still cost people money, but it will certainly be free for that person. And for people that aren't on concession cards like myself, or maybe many people in this room, if you're spending $31 per script, that adds up, but you need to spend at least $1,600. I think that there's a combined one for couples, maybe. But once you've hit that, then those people can apply for a threshold card, and then all of their medicines will be $7.70 from that point onwards until the end of the calendar year, when it all clicks over.
All right, thank you. It's such a unless you're told about these things, it's amazing how much there is of information that you're just not aware of. So Kathryn has put in a question or a comment from Kathryn Reed, is Kate Reed. She says, thanks, Kathryn, for a great presentation. I have been pushing for some time now after the revision of the palliative care schedule to include oxycodone. Do you have any insight if this is going to occur, as remains caught up in the prescribing data in general schedule, so all palliative care prescribing of oxycodone goes unmeasured?
Are we talking about oxycodone in regards to injectable oxycodone?
Maybe you could unmute yourself, Kat. Yeah, there you go. Thanks.
Yeah, no, I'm talking about, hi, Kathryn.
Hi.
I'm talking about no, oxycodone, just tablets, because it's still only just on the general schedule. So when we did the revision of the palliative care schedule, it wasn't picked up. It was the only one in the suggestions that we had that wasn't picked up, and so it's caught up in that in the general prescribing. So people are particularly GPs who are working in, and nurse practitioners, I would assume too, working in residential aged care, get pinged a lot and get audited for their oxycodone prescribing. But and then when they prove that it's palliative care, they go, oh, don't worry about it, that's fine. But if that was on the palliative care schedule, then we could pull it out of that, and palliative care prescribing wouldn't be as much of an issue for oxycodone.
Yeah, look, to answer your question, I don't know what's happening in that space, Kate. And it might have been perhaps when, I mean, look, oxycodone seems to be the drug of choice and has been for a long period of time, whether that's right or wrong. But yeah, I'm not really sure why that didn't get included. I think what you're talking about is that palliative care schedule, really, isn't it?
Yes.
Where you can get larger quantities with streamlined authorities, and
but it also is the AIHW data that comes from prescribing, so that we actually do understand what palliative care is using. It comes out of the PBS prescribing, and I believe most of it does there, and so that makes it really difficult because we can't predict or read our data.
Yeah, look, I don't know why, Kate. I can certainly have a look into that, but because we're not sort of in that aged care space in the background, it's not something that I've sort of, necessarily been too aware of. But no, I don't unfortunately know the answer for that, really.
Thank you. We're happy to chat offline if you wanted to.
I think the other thing that really stood out to me, Kathryn, was when you had that slide about the cost of midazolam. It was something like $40 a box of 10. And I think if you're a community palliative care nurse that's here, it's something, it's so great to be aware of. And so Kathryn, thank you very much for speaking to us all, because really the quality use of medicines isn't something that we get taught routinely, but I think it should be something that we palliative care nurses, especially community palliative care nurses, are aware of. So thank you.
Yeah, and I think that sometimes we default to midazolam, just having it there. I tend to put Rivotril drops in unless I'm concerned that there's going to be, significant respiratory distress or other agitation that's not going to respond to Rivotril drops. That certainly seems to be my first line. Because of the cost of it, really. So yeah.
And unless you were at a chat like this, you probably wouldn't really know, would you? So
well, now you'll all be going, oh, I don't know.
No midazolam. Now,
no midazolam for you.
Before everyone leaves, Kat, so mine's got
yeah, I tried to send a question, but it says that it's only sending it to Leanne Batty. But
Leanne, I know we know Leanne.
Yeah, but so also when you were saying about some of the medications, so like the support meds that perhaps the cost non-PBS may not use them, may not be choosing to pass at home. Are we requesting them too soon in the process, given that these medications may just sit at home and not be used? And
so that's certainly something that at EPC we've looked at over, and especially it came about actually when I learned more about quality use of medicines, because previously when I first started working here, people got admitted and bang, the request went off without really any thought.
Kind of what,
Well, I'm kind of hoping that doesn't necessarily happen all the time, because I do think we need to be considering if the person lives alone and we haven't determined a reliable, so it's not a blanket rule that they can't have them in, but if we haven't determined that a reliable, there's a carer that would attend, then I don't put them in. If someone's telling me that they don't want to die at home, they want to die in a PCU, and they don't have overly complex symptoms, then I choose not to put them in until, review it over time, because people can change their mind. But I definitely think we should be considering it. But I think it's always been a catch-22 in the community. Sometimes we get nervous not having them there because we never know when the crisis is coming. So, it is, and someone has put that, consider prognosis, the background of disease, essentially what symptoms we might expect. So, I think that they should all be the things that we're thinking about after we assess someone before we send that request off. Do I think that these are going to be
trigger type situation, like, well, maybe when
Yeah.
we get to this point, this is when we need to be thinking about having.
And that's why, obviously EPC, I'm bang on about the support medication care plans, so that we know that we haven't put them in, why we haven't put them in, and that people are reviewing that when we go to so that we get them in at the right time if they need it.
Thanks,
Thank you.
Simone. It's a good question, because it's just about being deliberate and considered about what we do, really, isn't it? So, look, thank you, Kathryn, for coming and speaking to us today, and everyone for attending. Now, before you leave, James, our secretariat, just asked in the chat there if you could let us know how you heard about this webinar today. And before you leave the webinar, if you could put it in the chat as to how you figured out this webinar was on, that would do us a tremendous favour, because then we know how to get it out to you next time. Membership, great. So look, Kathryn, thank you so much. We're very, very lucky at EPC to have you. But now the Palliative Care Nurses of Australia have been lucky to share a bit of your knowledge and expertise too. So thank you very, very much, everyone, for attending.
Thank you. Bye.
There's a lot.